We're here tonight for an MS Neuro TV program. We've been doing MS Neuro TV since prior to the pandemic, when we did it as a video recorded program, and then we had our presenter come online just to do the Q&A portion with our attendees. All right, so what do we have tonight? Well, we have me. All right, so for those that don't know, that's me, a younger version, all right, a little thinner version, but, you know, we're doing well. So, by the way, everybody, and before we even get into this program, I am right now 30 days approximately past being diagnosed with COVID. Don't I look great? I feel very blessed that that I came through it pretty damn good, all right, and I only can blame it on that I was vaccinated. And for those that are not vaccinated, I'm sorry. I do know a lot of people that are not vaccinated. I don't think it's right, but you do have your way. You have your own thoughts. And I just hope that you don't catch Omicron or Delta or any other variant that we get. And for anybody that does, I hope you do well with it, as I did. Okay? All right. This is an MS Views and News program. And we are supporting this series as we go forward. And tonight we have a special guest. Tonight we have Karina Siracusa, and Karina Siracusa is she's a pelvic floor physical therapist, doctor of physical therapy. She's a lot of things. She'll explain all that later on. But I want to let you know that Karina has spoken for us in the past. She one time was one of the presenters at one of our symposiums, and that was awesome. And for those that don't know, our symposium is an MS Views and News once a year event. It's like 5 or 6 different presenters during the day. We used to do all these live in person, you know, down in Davie, Florida. Now we're, you know, for the last 2 years, we did it virtually. And in 2022, this year, we're going to go back to doing it in person and virtually. So we'll have some of our presenters live and right there, and the others, well, they'll just be online. So going back to Karina, though, let me tell you a little bit. So Karina works at Ohio Health, and she's in the Neuro Rehabilitation Center. And this is in Columbus, Ohio. And I don't want to keep going on and on because it's Karina's hour, all right? So you ready to take it away? Dr. Siracusa, maybe you should say. All right, great.
Thank you so much.
Thank you. I'll see you back in 40 minutes, okay?
All right, sounds good.
Thank you.
All right, everyone. So thank you very much. Let me just introduce myself and kind of tell you a little bit more about what pelvic floor physical therapy is before we get started. And I'm going to be giving you kind of a high-level overview of what different types of issues in MS are common that can be treated by pelvic floor physical therapy. At the end, we will talk specifically about what kinds of things we do in therapy, and also how you can find a pelvic floor physical therapist in your area, because we are everywhere. There are not a ton of us out there, but we are everywhere. So I am a physical therapist, and I went to PT school. I got my doctorate in physical therapy in 2005 from Ohio University, which is in Athens, Ohio. And as a doctor of physical therapy, you learn a lot about the different specialties in PT. I actually started off as a pediatric physical therapist for the first couple years that I was working, but really got into pelvic health about 2 years into my career. And that's really where I got the most interested in working with people with neurologic disorders with bowel and bladder issues, because my background was pediatrics, which is mostly neuro. So I was just moving. I used to joke all the time that I got out of peds because I was tired of being thrown up on, and I got into adult pelvic floor therapy where I got peed and pooped on. So different bodily fluids, same type of work that we're doing. But the reason why pelvic floor therapy exists and why a physical therapist might see you when you're peeing your pants is because often it is due to issues with your muscles. It's just the muscles that we don't talk about very much. It's the muscles that we don't necessarily see. So that's what I'm going to be talking to you about tonight. A little bit more about my background too. All those letters after my name. I know it's an alphabet soup after my name. So after I started working in pelvic health, I went ahead and got board certified in it through the American Board of Physical Therapy Specialties. That's with the WCS, it's Women Certified Specialists. And then the ONCS is I also work with people that have cancer for pelvic floor and other disorders. And so that is what the ONCS or the ONCS is after my name. So I'm double board certified. I joke that I'm just trying to get more letters after my name than in my name. And I am currently completing a PhD, so I will have that after 2023. So then I'm done. If I go back to school after that, then somebody needs to probably commit me to a mental institution because I've gone too far. So let's talk about pelvic floor physical therapy. Oh, and as Stuart said, I work in Columbus, Ohio for Ohio Health in the Neuro Rehab program. Just as a disclosure too, so I do teach this all over the place. Specifically, I do teach for the Academy of Pelvic Health, which is a division of the American Physical Therapy Association, and I also run some independent courses. So just a little bit more about my background and why I've been talking about this all over the place. So this picture, what you'll see is your pelvic floor muscles. And these muscles are small but mighty, but the reason why they get weak for so many people is that it's really hard to kind of see what they're supposed to be doing. So, you may have gone to other talks where we talk about different exercises for other parts of the body. It's really easy for you for me to show you how to work your biceps, for instance. I'm going to move my arm up and down, and that's going to work your biceps. It's a lot harder for you, as you can see, to actually be able to move these muscles and understand how to move these muscles. So you can see from the picture that these muscles we call them bowl shaped. So they run from sit bone to sit bone. So if you're sitting on your butt, you're sitting on your pelvic floor muscles right now, and then pubic bone to tailbone. And they form kind of a bowl. Okay, so they sling underneath your pelvis. And what the other thing that I'm going to talk about in a little bit is they're the opposite of your diaphragm. So your pelvic floor sits down here, your diaphragm sits up here, and together they kind of move up and down as you breathe and as you move and as you walk, and they help to control bowel, bladder, and sexual function. The other muscle that I want to point out really quickly on this picture too is the muscles on the side here, and that is the hip muscles. So they are attached to your hip, but they also are attached to your pelvic floor. So there's lots of different issues that can arise if you have weakness or pain in the hip or in the pelvic floor that can cause some of the problems that I'm going to talk about. So moving on, we have just to show you the difference between the male pelvic floor muscles and the female pelvic floor muscles. So the main difference between male and female pelvic floor muscles is that men have 2 holes and women have 3 holes, and that's about the only main difference between these 2 sets of muscles. But I like these pictures because they show, one, how similar the 2 sets of muscles are, and then 2, just that there are superficial muscles. So there's muscles that are a little bit closer to the surface, and then there are deeper muscles that are a little bit further up in the pelvis. And they both have different functions. So our muscles that are a little bit closer to the surface, and you can see those a little bit easier on the picture on the left of the male pelvic floor. So the muscles there that look a little bit like a triangle, those are your superficial muscles. And those muscles are primarily responsible for sexual functioning. And then the deeper muscles are the ones that are responsible for urination and defecation. They all need to be strong, though, for all of those processes to really be working properly. So next, we're going to talk about bladder complications of MS. And before I actually say that, the one thing I want you to remember about those muscles that I really try to stress. I talked about sexual function, but they also have a supportive function, meaning they're supporting all of the organs in our pelvis. And then they have what we call a sphincteric function. So they are keeping everything closed until we are ready for it to open. And that's going to lead into the things that I'm going to talk about here. So supportive, sphincteric, and sexual are the three main functions of your pelvic floor muscles. So let's talk about bladder complications first. And when I see patients with MS, this is probably the most common thing that I will see patients for is their bladder dysfunction. The bladder dysfunction is often one of the first signs of MS, but the problem is that bladder dysfunction can be chalked up to a lot of different things. So for instance, those of you that are women probably have heard kind of the misnomer or the miseducation that, oh, if you've had a baby, it's normal to pee your pants. Or if you've had a baby, it's normal to have to run to the bathroom every 15 minutes. Or if you're a man, oh, you're getting older, your prostate's getting a little bit bigger, and so it's normal for you to have to get up a bunch of times or to have to keep going to the bathroom. And that's simply not true. There are factors to aging and childbirth that can cause some bladder issues, and so that's why they're often ignored at the beginning prior to the diagnosis of MS. But the MS is going to be a factor in why some of those things are happening. Now, bladder issues will be experienced by up to 96% of patients with MS. So this is why I said the majority of patients that are coming to see me for issues of the pelvic floor have some sort of bladder issue. They may have some other issues as well that we're also going to take care of, but bladder stuff is usually what kind of brings people into my office in the first place. Often bladder issues are not reported until up to 10 years after the first evidence of disease activity. So that's what I was saying, because a lot of people will just chalk it up to those other things that I talked about, previous things that have happened in their life. They're not always going to talk to their neurologist about it. They will say like, oh yes, I am going to the bathroom all the time, but it must be because I had a baby and not necessarily because I have MS. Well, I'm going to tell you that it's a little bit of both. So you may have kind of had, some predisposition to some of those issues, and the MS was the kind of the proverbial straw that broke the camel's back when it comes to your bladder issues. So it is really important that if you are having any of the things that I'm about to talk about, that you definitely talk to your neurologist about it. Now, I stress the neur because I talk about neurologist and urologist, and I talk really fast. So if I don't stress the first couple of letters, sometimes you don't know who I'm talking about. But the neurologist may refer you to a urologist, and we'll talk a little bit about that. So some of the most common complaints with MS and the bladder, the first is urgency. And so what urgency is that's the I gotta go right now. It's the you don't feel like you have to go to the bathroom. All of a sudden it hits you and you're running to the bathroom because you feel like if you don't run, you are going to have some incontinence. You're going to pee your pants. And so what that leads to then is the second thing on the list, which is frequency. Our bladder ultimately is a muscle. It's not a muscle we can control. It's what we call smooth muscle in the body. So it's not something that I can make stronger. But if you don't continuously stretch out your bladder to a fuller capacity, then it can actually start to get smaller. So if you are running to the bathroom, the minute that you feel like there's something in there, and let's say there isn't a whole lot, your bladder's not all the way full, then what it's going to do is it's going to take less and less urine for that bladder to feel like it has to go. So that leads to the frequency. You're going multiple times an hour, and it starts to really interfere with your life. And then the last thing that we can see most commonly in MS is urge incontinence. Urge incontinence is when you have that urgency and that frequency, but you also leak when you have that urgency and frequency. So usually that's a kind of a progression from first to least. You usually start with the urgency, then you develop the frequency, and then finally the urge incontinence. Now, the one thing I don't have on this slide is stress incontinence, and that is when you pee, when you cough, laugh, or sneeze. And while that is experienced by people with MS, that is more likely caused by some of those things I already talked about, like having a baby, like coughing a lot, like having prostate issues. So stress incontinence is more of your garden variety incontinence, and is often, it can be made worse by your MS, but usually the primary issue is not your MS. Now, other bladder complaints that we can see from patients is hesitancy, which means that you have trouble starting the flow of urine. You sit down on the toilet and you may have to sit there for a few minutes. Even if you really feel like you have to pee, you might not be able to really start that flow right away. Interrupted stream means that your stream is kind of starting and stopping. So you go ahead and you start to urinate and then it stops, but you still don't feel like it's completely empty. So you try to go ahead and go a little bit more. That's also the same as incomplete emptying, meaning that you urinate and you get up, you wipe, you pull up your pants, you wash your hands. I hope you're all washing your hands, and you walk away and you have to urinate again, maybe 5-10 minutes later. That's that feeling of incomplete emptying, and that doesn't necessarily mean that you aren't emptying all the way. Sometimes what can happen is that after you urinate, your bladder, normally what happens when you're peeing is that your bladder is contracting like a balloon to get all the urine out. If it continues to contract even after it's empty, you're going to feel like you still have something left in there, even though you don't really have anything going on. Double voiding is where you kind of stand up and then have to sit back down again. Or some people will experience, they think that they're finished and they stand up and a little bit leaks out right after they've stood up. Now, nocturia is getting up multiple times a night to urinate. And that is one of those things that is generally not fixed by your pelvic floor or caused by your pelvic floor. Nocturia is usually caused by a couple of things. One, it can be caused by swelling. So if you have a lot of swelling in your lower extremities, when you lay down, that swelling kind of goes back into your system and is processed by your kidneys and goes into your bladder. So it fills your bladder up a lot faster. The second reason for nocturia or nighttime peeing is poor sleep. What should happen when we go to sleep is if we get into a good deep sleep, our kidneys actually slow down the production of urine. And so that's how you normally can kind of go 8 hours without peeing, even though you might not go 8 hours without peeing during the daytime. It's because your kidneys are actually producing less urine when you sleep well. So if you're not sleeping well, then your kidneys are going to continue to produce urine and you're going to get up a little bit more often. For men, they can also have something called benign prostatic hypertrophy, meaning that the prostate gets a little bit larger, and that can also cause nocturia. So generally, that's not a pelvic floor issue. That's an issue that's going to be taken care of by a urologist. And then the last one on that slide is enuresis. And enuresis is actually having incontinence in the bed while you're asleep. And that is also more of usually a systemic problem that is going to be taken care of by a doctor, because we need to know why you're not waking up when you have a full bladder. So if you are experiencing either nocturia or enuresis, those are definitely two things that to talk to your doctor about, because they're going to require some further workup. So moving on from the bladder complications. So Excuse me. So you can't rely on subjective history when it comes to the bladder, meaning that, I gave the example of the incomplete emptying where patients will tell me, I swear I am, emptying, I'm not emptying fully, like there's something left in my bladder. And so what we might do is something called a bladder scan, where we'll have you urinate and then we will do an ultrasound on your bladder where we can tell exactly how much liquid is left in that bladder. And so sometimes what'll happen is that they will feel like they're not empty and they actually are, and that's that bladder overactivity that I talked about. Or they may feel like they're empty and they are still have a decent amount of urine left in there. So only 47% of patients with a high post-void residual, that means how much urine is left in your bladder after you are done peeing, actually reported feelings of incomplete emptying. And that's kind of some of the, lots of people will tell me, they'll have numbness or tingling, or they can't rely on what their nerves are doing. It's the same for your bladder. You can't always rely on the signals that your bladder is giving you. And that's why that high post-void residual will continue to exist. Also, greater disability and recent relapse are associated with increased odds of being bothered by bowel and bladder symptoms. And so what that means is that anytime you have a relapse or a flare, you are going to have a worsening of your bladder symptoms, and you're also going to be a lot more bothered by them. Usually because if you're having a flare and you're having some increase in physical disability, now it's going to be that much harder for you to actually get to the toilet. So we definitely want to make sure that we're taking care of you, taking care of those bowel and bladder issues during a flare. And that post-void residual might be the only tests that many neurologists will do with their patients. Urologists will do a variety of other tests with you, but most neurologists will do that PVR just to check on your bladder. So there are two different reasons why we will have bladder dysfunction. And one, I as a physical therapist can help, and the other one is going to be more a urologist and probably going to be more medication-based, or possibly, even if it's bad enough, surgically based. So with the muscle, the types of things that I'm treating are stress urinary incontinence, which, as I said, is where you leak when you cough, sneeze, or laugh. So essentially what is happening in stress urinary incontinence is that there is an increase in downward pressure on that pelvic floor, and your pelvic floor is not strong enough to close the sphincters. Remember I said it's a sphincter and a supportive muscle. It's not strong enough to close that off and support everything. And so when the pressure pushes down, it pushes on the bladder and pee comes out. So obviously you can tell from that definition that if the main problem is weakness in the muscle, if we strengthen the muscle, that stress urinary incontinence will go away. Urge urinary incontinence is a little bit trickier to kind of take care of. It still sometimes will involve muscle strengthening. Sometimes it will involve some what we call behavioral interventions. I like to call it potty training for grown-ups, where we try to reverse some of the bad habits that they have developed from having that urgency and frequency. So things like restricting fluid intake, which actually can make urge incontinence worse, or trying to stretch out those intervals of urgency. So all of that can be helped with the muscle treatment. Now, bladder pressure and prolapse pain are also, that's that supportive function that I was talking about. So the pelvic floor supports the visceral organs on the inside. So your bladder, and for women, your uterus, if you still have it, and then your rectum. And so if you think about your pelvic floor is like a trampoline, okay? So if you have a trampoline with all of its springs intact, and you put a bowling ball in the middle of that trampoline, it's probably not going to sag very much because all of those springs are holding it up. Now, if you pop some of the springs on that trampoline and those springs are no longer holding the middle of that up, when you put that bowling ball on the middle of the trampoline, it's going to sag way down. So that's essentially what happens when your muscles aren't strong, is that it causes all of your organs to push and sag, and that can be really, really painful. So patients will tell me that it feels like heaviness, or they'll feel like they have a bowling ball between their legs. That's kind of why I use that analogy. So that also can be helped by muscle strengthening. Now, the visceral things are things that I can't necessarily fix with pelvic floor physical therapy. They may get a little bit better, but I can't 100% fix them. So that pure urgency is often due to what we call overactive bladder, or that bladder squeezing too much when it's not supposed to. And that's often going to be fixed by some medication. Some urge incontinence requires medication as well. Now, the pelvic organ prolapse that I just talked about with the springs, we can help shore those springs up, but there is a certain point where pelvic organ prolapse kind of goes past the muscle strengthening piece and may require surgical intervention. And then urinary retention. So if you go into a pure, what we call neurogenic bladder, what happens is that sometimes that bladder can stretch out so far that it stops contracting altogether. And those are the patients that will see me that we have to work on catheterization. Once you get to that catheterization standpoint, we are just looking at optimizing function within catheterization. That's not something that we can really reverse once you start to need it. And all of those things on the visceral side will be taken care of by a urologist. So moving on to bowel dysfunction. So as I said, most people end up coming to me for bladder dysfunction, but often what will happen is, as I kind of talk to them about their bladder dysfunction, they will tell me that they do have a long-standing history of constipation that they didn't think they could do anything about. And so there are some things, it's just like with the bladder. There are some things that are more visceral in nature that we can't do much about, and then there are some things that we can. So let's talk about bowel dysfunction specifically. The most common bowel dysfunction, really in any patient, truthfully, is constipation. And I think all of us have been, whether you have MS or not, all of us have been constipated at one point or another. And it gets very uncomfortable when you're constipated. And so there are multiple different reasons why somebody with MS can become constipated. It can be behavioral, it can be because the gut slows down, or it can be due to some muscle dysfunction where your muscles are not relaxing enough in order for you to be able to evacuate stool. So there are two different reasons why bowel dysfunction happens in patients. So the first is what we call dysinergia, and that is a fancy word for my pelvic floor muscles won't relax and allow the poop out. Okay, so dysinergia happens normally when we are having a bowel movement. A lot of people think that when you're bearing down and you're straining, you are actually kind of pushing the muscles open. But what you're doing is you're relaxing the muscles and you're not contracting. You're allowing everything to open and create that relaxation in the sphincter muscles. So what dysinergia is when you're trying to bear down and you're pushing and you're saying, huh, and you're really kind of giving it your all, the muscles are clamping shut or moving shut. And that dysinergia is keeping you from being able to get the stool out. Now, the second type of constipation is what's called slow transit constipation. And this is exactly what it sounds like. So normally it should take, when you eat something, it should take between 48 and 72 hours for it to get from your mouth out to the toilet. Okay. Now, one of the easiest tests that you can do to see how you're doing with this is to eat some corn and then measure how long it takes for it to all come out. Corn is I always joke that it must have like zero nutritional value because it looks the same coming out as it did going in. So if you eat some corn and it is coming out in 24 hours, then you might have some too fast of a gut. We might need to get some fiber in you and some things to kind of slow things down. If you eat some corn and it's coming out a week later, then you know you have some slow transit. Things are moving far too slowly in the gut for you to get all of that stool out in a timely manner. And there's lots of different reasons really why you can have slow transit constipation. Not drinking enough water, not drinking enough or eating enough fiber. Some people can just have it congenitally. So there's lots of different reasons why you can have that. As you can probably tell, one is a problem with the muscle, Dysinergia, and the other one is a problem with the viscera, slow transit. So the Dysinergia, I am probably fixing as a pelvic floor physical therapist. The slow transit, I can help optimize function, but we may need to work with your gastroenterologist to figure out why exactly everything has gotten too slow in that gut. So the other thing that can happen is if that constipation gets really bad is something called an impaction. So usually an impaction starts off as constipation. So everything kind of slows down. And what I always joke is that our rectum, which you can see kind of at the end of the colon there, is a storage facility, but it's short-term storage, not long-term storage. Meaning that if stool stays in there for too long, it starts to send a signal to the rest of the colon, slow down, guys, we can't get anything out of here, so we need to slow everything down and not put anything else in the rectum. We're getting too full, we need to shut it down. And so if that's shut down long enough, or if the stool continues to be hard, it can get so impacted in the gut that then it can't move after that. So an impaction or constipation, those two things are really something that we have to definitely take care of. An impaction becomes a medical emergency and is usually has to be either cleared out with an enema if it's mild, or sometimes even has to be cleared out surgically if it gets to be pretty severe. So, and I'm going to talk about kind of how we fix those things here in a second. But one of the last things that we really treat from a pelvic floor physical therapy standpoint is sexual dysfunction. And I'm sure you're thinking, how is doing some Kegel exercises going to improve my sex life? Well, as I said at the very beginning, those superficial pelvic floor muscles actually have a pretty serious role in sexual functioning. So without the strength of those muscles, we can't experience orgasm. And for men, without the strengthening of those muscles, it's going to be very, very difficult to obtain and maintain an erection. So there is a lot that can happen when the pelvic floor muscles are weak in regards to sexual dysfunction. So let's talk about a couple of those things now. There are many factors that affect sexual functioning in MS. The fatigue is usually a big one. If you are too tired, you're definitely not going to want to engage in any sort of sexy time with your partner. So that's obviously something that we will address, at least from my standpoint, from a PT standpoint, behaviorally. So looking at positions that are easier for you to get in, or times of day when it might be better to try and engage with your partner. Spasticity is another big one. So, spasticity may prevent patients from being able to get into certain positions for sexual functioning. And so, again, we may work on the physical side of that to figure out what's going to be easiest for patients. Pain obviously is going to be a big limiting factor in sexual functioning. But bowel and bladder dysfunction is in there. And so, what I always say is no one wants to try and have sex if they're going to be worried about peeing their pants or pooping their pants the whole time. That's not real conducive for most people to sexual functioning. So sometimes it's an added bonus that as we work on the bowel and bladder issues, then the sexual functioning improves as well. However, the same thing that causes bowel and bladder dysfunction, weak muscles, can also cause anorgasmia, meaning not able to have an orgasm, or difficulty with erection. And then finally, mood disorders, mainly because most of the medications that are given for mood disorders blunt libido. So that's one of those things where if you are on a medication that for depression, for instance, you might want to talk to your doctor if it's really bothering you from a sexual standpoint, and they may be able to adjust your dose or try a different medication that doesn't have the same sexual side effects. The incidence of sexual dysfunction in MS ranges from about 62 to 83%. And one of the hardest things is that most, not all, but a lot of physicians won't necessarily ask about it. So, and then patients are afraid to talk about it because they really don't know, one, if the physician will have any sort of solution for them, or two, if they even care. So I can tell you that your physicians do care. Definitely talk about it. Definitely make sure you bring it up in your appointments, and there are different things that we can do for it. Now, with sexual dysfunction in men with MS, erectile dysfunction will occur in about 70% of men who have sexual dysfunction with MS. The mean time between the onset of MS and erectile dysfunction is about 9 years. So unlike the bowel or the bladder issues that we talked about at the beginning, sexual side effects or sexual dysfunction is usually not one of the first things that happens after the diagnosis of MS, but it's usually cumulative to a lot of the things that I just talked about. Now, the ability to sustain an erection is largely dependent on what we call psychogenic erectile drive. So there are two different types of erections. There are psychogenic erections, which means you see somebody or something that you're attracted to, or you see an image on the screen that you're attracted to, and that causes an erection. And then physiologic erections are the erections that men will get first thing in the morning when they wake up. And so it's not the physiologic erection that is always an issue in MS. It usually is the psychogenic piece of it. And so Viagra is the most common treatment for that. However, it does take some planning, and it can cause, or it can prohibit sex from being as spontaneous as some people would like it. Now, moving on to sexual dysfunction in women with MS, there are a couple of different reasons why this may happen. One can be diminished lubrication. Diminished lubrication usually happens in women that are getting close to or have gone through menopause. And that is because lubrication is dependent on estrogen in women. So if we start to lose our estrogen, we will decrease the amount of natural lubrication that we will create in our bodies. And so that's usually a pretty easy fix. The gynecologist will usually prescribe a drug called Premarin or Esterase, which is an estrogen cream that is put directly on the vulva. The good thing about those estrogen creams is that they're not systemic, meaning they're only going to the place where they need to go. So there is no risk of any systemic side effects, a la an increased risk of cancer, by using some of those creams. So definitely, if you are experiencing pain, like a rubbing or a raw pain, or do not feel as much lubrication during intercourse, talk to your gynecologist about it, because there are several drugs on the market for that. Sometimes there can be sensory disturbances, and I have had a couple of patients that have lost sensation and lost feeling around their clitoris, their vulva. And unfortunately, there is not a lot we can do about that from a muscle standpoint. We can try and strengthen the muscles and see if that was causing some issues, but if it is primarily a nerve issue, then there are more things that a sexual medicine doctor may be able to work with you on in order to try and get that sensation back, but that's more directly related to the MS. The other thing though is, the weakness that I talked about and the bowel and bladder issues that we most commonly see in women. Now, the real hard part is that there are very few medications or treatments for sexual dysfunction in women. There were a couple of drugs that were on the market there for a little while, but most of them have been taken off market. And also even the ones that didn't have great results as the same as Viagra in men. There was one small study that looked at Botox for bladder dysfunction, helped with sexual functioning, but the reason for that is that because the women were less worried about having urinary incontinence, that's why their sexual functioning improved. So we've talked about the three different things that can, be affected by the pelvic floor. Let's move on to what types of physical therapy treatment are available for some of the things I just talked about. Now, I will start with, as a physical therapist, I am charging for physical therapy. Yes, it's physical therapy for down there, like we like to say sometimes, but it's still physical therapy. So most insurance plans will pay for PT and for pelvic floor PT. There are some places also out there. There are some therapists that have cash-based practices. That if you can't find, or if your insurance deductible is too high, often the cash-based practices will charge a little bit lower fees. So I'm going to kind of talk to you through how to find that. So, what do we do? On the evaluation, for me, I'm generally talking the first part of the evaluation, because I need a really good, solid, subjective history. So first, I'm going to ask about when did the symptoms start, prior to their diagnosis of MS or after? And what that's helping to tell me is, is this a pre-existing problem? And then as I said, the MS exacerbated it, or was this problem kind of revealed by the issues that they're having with their MS? What are their primary symptoms? So, and I also ask, kind of what do they care about the most? I have lots of patients that come into me and they're like, I don't care about the fact that I'm constipated. I just want to stop peeing my pants. And so that's what we're going to kind of work on first, was whatever is most important to the patient. How are they dealing with their symptoms? So the reason why I ask this question is a lot of times people will make accommodations or modifications to what they're doing in their daily lives in order to deal with their bowel or bladder issue. For instance, as I said when I talked about the bladder stuff is, I'll have patients that have a lot of urgency. They will go to the bathroom multiple times a day, and that leads to going even more times a day. And then, before you know it, they're going every 20 to 30 minutes. So, or I'll have patients that will restrict their fluid intake because they'll say, well, if I just don't drink anything, I won't pee. I got news for you. Your kidneys make urine whether you're drinking anything or not. So if you're restricting your fluid, you're actually shooting yourself in the foot because you're causing your urine to be way more concentrated, which makes it way more toxic to the bladder, which means you're going to pee more often. So, so some of those behavioral things we have to kind of reverse before we can even start on any strengthening. What medications are they on for their MS? There are certain medications that will make bladder symptoms worse, and there are certain medications that will make bladder symptoms better. So during your subjective history, we'll kind of talk about that. Even if you are on one of the medications that makes your bladder symptoms worse, that doesn't mean that we can't then kind of fix those bladder symptoms or make them better. It just means that we may have to do some different tactics in order to improve those bladder symptoms. And then what medications have they tried for their bowel and bladder symptoms in the past? And that's just because I don't want to reinvent the wheel. If they tried something in the past and it didn't work, I'm not going to suggest it this time. And also, I forgot to add on that slide too, I'll ask them if they've seen a urologist yet. Everybody should see, if they have really significant bladder issues, should be seeing a urologist on at least a yearly basis. And so sometimes part of what I'm doing is connecting them with that urologist. I start with bowel and bladder diaries. It's not Dear Diary, this is what my bladder thinks today, but instead it's looking at how often are you having, how often are you peeing, how often are you having a bowel movement? When you are going to the bathroom, how often are you spending on the toilet? Are you sitting there for a really long time, or are you peeing only a little bit and you're up and away? What's your toilet awareness? Meaning, do you have that urgency? And are you having any difficulty wiping as well? And the urgency goes for bowel or bladder, whether or not you're having urgency to pee or if you're having urgency to poop. So moving on. So this is just an example of a bladder diary that I might give you. Usually I'm going to have you fill out the bowel diary for a full week and the bladder diary for at least 3 days. So we're going to start with education. And you don't know what you don't know. The majority of people, when I tell them, yes, you're going to the bathroom a lot, and one of the first things I want you to do is I want you to drink more, they look at me like I'm crazy. And they're like, why do you want me to put more fluid in my body? Isn't that going to make me pee more? And so that's how I'll do a lot of education about the physiology of the bladder and exactly how it works, so that we can make sure that you're drinking the appropriate amount of fluid. And then from a food standpoint, I'll look and see, especially if you have some constipation, I'm looking to see if you have enough fiber in your diet or what kinds of things that you're eating that could be slowing down those bowels and causing that slow transit constipation. From a manual therapy, this is things like bowel massage, or if the patient is having a lot of pain, internal pain, we may try to work those muscles and stretch them out a little bit. And that generally requires my hands being on or in a patient, because we do internal treatment in pelvic floor physical therapy. So sometimes I may be going in vaginally or rectally to release some of that muscle tightness and get those muscles to relax. We're going to do therapeutic exercises. So part of that is Kegels, which you may have heard of, but I do not just prescribe Kegel exercises all day. That would be super boring on my part. So we are going to look at the whole body. So how does the pelvic floor interact with the diaphragm? How does the pelvic floor interact with the abdominals? And are those muscles working synergistically properly? So I do a lot of breathing work. I do a lot of core stability, and we do a lot of coordinating pelvic floor contraction and relaxation with those other muscles. If it is a mobility issue, and that's one of the reasons why you're having trouble getting to the bathroom, I may refer you on to my neuro colleagues just to make sure from a mobility standpoint that that's not causing things. And then transient irrigation is something that we will possibly do if you are really backed up and you're having a lot of constipation. It's basically like an enema, and we may prescribe that in order to get you cleaned out so that we can kind of start from scratch and improve that bowel health. So this is something called abdominal massage that I will sometimes do with patients. That's part of that manual therapy treatment that I was talking about. Abdominal massage is a really great thing if you're constipated and it just feels good on your belly. What you can see is that you're kind of doing just some circles, and you're going up your right side, over underneath your ribs, and then down your left side. And so I'll show patients how to do that in the clinic to help relieve some of their constipation, and it can also help relieve bloating and gas as well. We talk about the correct posture for having a bowel movement. So when you are in a squatted position, as you can see on the picture on the right, you can actually relax those muscles a little bit easier. You're putting yourself in a better biomechanical position in order to relax those pelvic floor muscles. And so that's, we will kind of make sure you can get into that position physically. And if you can't, we'll look to see what kind of modifications we can make to relax those muscles. We do talk about Kegel exercises. That's part of the reason for my internal exam, because it's really, I can really only feel if those muscles are contracting appropriately, if I can feel it either vaginally or rectally. So we'll teach you how to do those exercises. If fatigue is a factor, we'll prescribe the number of holds and rests appropriately so that we're not fatiguing those muscles out. As I said, we'll also do core stabilization exercises, things with your abdomen. Improved pressure management is making sure that you're not bearing down too hard, or if you're having issues with coughing, laughing, and sneezing, you can meet that resistance with your pelvic floor. And finally, breathing exercises. As I said at the very beginning, your pelvic floor is the bowl on the bottom, your diaphragm's on the top. So if you can't move that diaphragm really well, it's going to affect what's going on the bottom. So we teach you kind of how to coordinate those things and really diaphragmatically breathe so that you can contract and relax that pelvic floor. And then lastly, we may use some what we call modalities. These are things that are adjuncts when exercise by itself is not doing the trick. We can do something called electrical stimulation, where we actually stimulate the muscles to contract if we're not getting a good, strong contraction. We can use something called biofeedback, which is either EMG or squeeze pressure, where we can have you squeeze and you can either see it on a screen or the squeezing causes a vibration or movement. So that biofeedback is giving you feedback as to what those muscles are doing. And then rehabilitation ultrasound imaging is where we might actually use an ultrasound to see what your pelvic floor muscles are doing and see if they are appropriately contracting and relaxing. So in summary, I hope you learned a little bit about some of the things that are common with bowel bladder issues with MS. And you can see how many of them can be connected to the pelvic floor muscles and how they might be helped with actually pelvic floor physical therapy. Now, one of the best ways to be able to find a pelvic floor physical therapist is there is a website. It is aptapelvichealth.org. That stands for American Physical Therapy Association, Pelvic Health. And that has a PT locator on it that can find, so you can put in your zip code and find the closest PT to you. You can also Google pelvic floor physical therapists, and usually the American Physical Therapy Association website will show up for you. I've also included my email address at Ohio Health, so if you do have any questions after tonight and you want to email me, you are more than welcome to. So, but with that, I will go ahead and take some questions if there were any from the audience.
Hey, that was an awesome talk. Thank you very, very much for doing that. I am sure that everybody, and we have a lot of people online, I am sure that everybody greatly appreciates what you spoke about tonight. I mean, that was just incredible. So thank you very much.
Thank you.
By the way, if anybody sees me getting like shivers, it's because it is freezing where I am, and I'm in Florida, and it's like in the upper 40s here. It's just crazy, and I'm sitting here. I'm in a sound stage here, and it's just cold. All right, so we have a lot of questions. All right, we have questions that we had taken before the program started. We have questions, many questions that came in during the program. So let me begin with this one. And for everybody that's online, I know that I normally say a first name, but I will not tonight, okay? We're going to just respect everybody's privacy. So if you have a question, don't worry about it. I'm not going to be repeating that. There is a person that's asking if you can please repeat the name of the website for the physical therapist.
Yeah, so it is APTA pelvichealth.org. So APTA and pelvic health are all one word, and then .org. And that is, you'll see once you go there, there's a find a PT at the very, very top, and you can click on that and put in your zip code.
Okay, great. Thank you for that. And we are going to list that when we publish this to the YouTube channel, which will be in probably less than 48 hours. I'll make sure to include that that URL as well, so that way for anybody that checks back afterwards to see the video, then we will be able to you'll be able to see that as well. All right. So next, another person is asking. Do you recommend the squatty potty?
Yes. So yeah, I do recommend the squatty potty. That's where that picture was from. But really any stool will do. It doesn't have to be that brand name. So any stool under your feet will do, just because it does put you in that better position for having a bowel movement.
Okay. Thank you for that. Next one. Person's writing, I make life-changing bread with nuts and selenium. I can send the recipe, whatever.
Yeah, so, fiber is great.
Okay, another person's writing, could ischemic colitis be an effect of MS?
Ischemic colitis, not necessarily. Good. Yeah, ischemic colitis is an inflammatory process. It can be exacerbated by the MS, but likely that GI issue was there prior to your diagnosis and prior to the MS.
Okay, thank you. Given this type of colitis, would milk of magnesia be recommended to help with the pain?
That's something you really are going to have to ask your gastroenterologist. I can't really speak to that one.
Okay, thank you. Next person is writing, why does incontinence increase when I have a UTI?
Oh, that's a really good question. So usually when you have a UTI, that is bacteria, obviously, in either your urethra or your bladder. And so what's happening is it's irritating the lining of the urethra and the bladder. And so your bladder kind of keeps squeezing and squeezing and squeezing, and your pelvic floor muscles can't keep up. So usually if it's being exacerbated, it should get better after you're on the antibiotics for the UTI.
Okay, thank you. Next person, how do you get control of not being able to hold your urine? And continuing, either I start as soon as I get near the bathroom, or if I have been holding it for a while, but no matter how hard I try, I cannot hold it, and rely on a poise pad. Mm-hmm. I'm probably saying that wrong, which
no, you're right.
Okay, doesn't always work.
Yeah, so you are the perfect patient to go to pelvic floor physical therapy. So it's going to be a combination of, usually we start off with something called timed voiding. So instead of relying on the urge, I have you go at specific intervals. That's that potty training for grownups that I was talking about. So I have you go at specific intervals, and I would do that based on your bladder diary. So I would look at your bladder diary and then determine how often I wanted you to go. And so it's a combination of that, and then it's a combination of strengthening those muscles. So I would like I said, you're the perfect candidate to go see a pelvic floor physical therapist.
Okay, good. Next person, my problem with bowel dysfunction is that stool evacuates before I can get to the toilet.
Yeah. So that's often usually a muscle issue. The only other thing I would say is that if you are a woman and you did have a vaginal delivery, sometimes tears that occur during a vaginal delivery can also cause that lack of stool control. So again, I'd highly recommend seeing a pelvic floor therapist, because we can kind of tell the difference, and we can kind of see which of the problems, if it is just that the muscles are week, we can fix that. If it is that it's a pre-existing some scar tissue from that vaginal delivery, then we would refer you to the appropriate physician.
Okay, thank you. Another person, I'm going to ask my video producer to bring this up. A person is asking that you show again the picture of Kegel exercises. Now, do you know where that is? So that way my video producer can find that?
Actually, I don't. Yeah, I know what slide she's talking about. So that's not a picture of Kegel exercises. That's a picture of certain positions that you can be in for a Kegel exercise, or the combination. You can't, as far as when it comes to Kegels, you really have to be individualized, meaning I can't, the commonly must know facts about Kegels. So, really with that, you need to go to see a physical therapist so that we can prescribe it, correctly for you. Everybody's a little bit different depending on where you're starting from. You have to be able to do Kegel exercises that you can hold and Kegel exercises that you can do really quickly. So if you are concerned with it, like I said, I highly recommend seeing a pelvic floor PT.
Okay, great. Next person is saying, I don't have a problem with constipation. I have like very loose stools.
Yeah, so with loose stools, there's a couple of reasons for that. Usually things are moving a little too quickly in your gut, and so your gut's not able to absorb all the water from the stool and make it into solid. So I know it sounds counterintuitive because we tell people for constipation, you need to eat fiber, but for loose stools, you also need to eat fiber. But you need to eat like bulkier fiber. So I'm talking things like oatmeal, bananas, apples, and those things will help bind to your stool and make it to be a little bit harder. I also highly recommend for people with loose stools, get off of any of the man-made fibers. So things like Metamucil, because that will often cause loose stools, and instead try to get your fiber from food. And that can help reverse that.
Okay, thank you. All right, so a person wants me to tell you that this was amazing, very informative, and very easy to understand. So I just wanted to, let you know that before I delete it out. How's that?
Thank you. Okay. Thank you. I appreciate that.
All right, great. Next, I think you mentioned it while you were talking, but still a person is asking what useful tips you have for urgency.
Yeah, so again, timed voiding, just to repeat it, making sure you're not restricting your fluids, because again, if you restrict your fluids, it's going to make your urine more concentrated. So you probably saw me a million times taking a sip from my water bottle. My water bottle has these little lines on it so that I can kind of keep track of how much water I'm drinking. That's what I usually recommend to my patients, is to get something like this. There's lots of them on Amazon that you can find. And you want to make sure that you're drinking at least 48 to 64 ounces of water a day. And that will also help with urgency.
Wow. That'll help with urgency? I think I'd be stopping at every rest area on my way along the Florida Turnpike. Sometimes I don't have time for that. Speaking of which, and this is so often seen, why do many guys feel the need to, while they're urinating, to standing there and leaning against the wall, like as if the wall is going to help them release? And it's not for better, and everybody, I'm saying this, it's not for better aim. It's because it's easier to
relax. So there's two different reasons for that. That's a great question. So one is it could be that prostate hypertrophy that I talked about, which is benign, but can cause you to need to lean forward and get the bladder right over the urethra in order to let it out. The other reason for that, though, is that part of your pelvic floor, what I didn't talk about, is your pelvic floor is responsible for upright stability. So it means that it's always at a low level contraction. Otherwise, we would all be peeing our pants constantly. So for some guys, if it's a little bit overactive, meaning that it's a little bit on the tight side, leaning forward basically is taking your weight off your body and their weight off your pelvic floor and allowing those muscles to relax a little bit better. So I would, if you are having that problem and it is pretty constant, I would get checked out by a urologist first, just so that they can make sure it's not a problem with your prostate. And if it's not, then often pelvic floor can help with that.
Okay. Next one, similar, well, not really similar, but what is the recommended frequency for, not similar at all. What is the recommended frequency for a bowel movement if you are constipated?
So the problem with bowel movements is it's really subjective. So, with bladder, we know like how often you should go, but with bowel, it can be normal, can be anywhere from 3 times a day to 3 times a week. So what I usually rely on is stool consistency, meaning that if it's the hard little balls and it's like itty bitty little, or it's like really, really hard and dry when it comes out, you're constipated. If it looks like a Snickers bar, and I'm sorry for anybody that I ruined Snickers bars, but if it's formed and it's relatively soft but a little bit lumpy, that means that your stool's going through at the appropriate amount. So you can go, you don't have to have a bowel movement every day, but it should be a good consistency in order to make sure you're not constipated.
Okay, other than the impaction that you just discussed, are there any other dangers from being constipated?
It's really uncomfortable, causes a lot of bloating. I mean, nothing that is, life-threatening, but it's just really uncomfortable.
Okay, thank you. All right, so we have, my gosh, somebody asked me to ask a question. I forgot what it is right now, but I'll get back to that in a little bit, or I'll have to write it down. Meanwhile, how can a woman find the urethra if wanting to self-catheter or self-catheterize?
So you're going to go to see a nurse to help that. We will use a combination of mirrors because everybody's urethra is a little bit different depending on if it's well estrogenized or not. So I would highly recommend talking to a nurse about that, and they can really help you find the urethra a little bit easier.
So this person also wrote, what if her spouse cannot find it either?
Again, I would go to a nurse and they can help you find some ways that might make it a little bit easier. Sometimes it is a functionality of needing some of that estrogen in order to help find it a little bit better.
Okay. Some people talk about having this very stomach upset within an hour or so after eating spicy foods, and that causing, irritation. But you said that food is really not known to cause a problem unless it happens, within 12 to 48 hours afterwards. So what happens then with the people, though, that are eating spicy stuff that just doesn't agree with them?
Yeah, so generally what happens with that is that that's actually more of a functionality of the amount of stomach acid that your stomach is producing. So if you eat something spicy and it really irritates your stomach, what that causes is basically it speeds everything else up because your stomach is like, I don't like this. We need to make room in the colon so that we can get rid of this faster. So it causes you to basically clear out what was already in your colon. So you're not pooping out the spicy food. You're pooping out what was already in there to make room for the spicy food because your stomach doesn't like it.
So they're acting like Drano.
Exactly. That's exactly what it is. It's clearing everything else out. Yep.
Gotcha. All right. Next one is about a sphincter muscle. Only one half works, so I keep leaking with every cough or sneeze. I keep trying to do Kegels, but hard to know if the non-working side is responding or not. Any helpful ideas?
So again, that's really where you need to see the pelvic floor physical therapist, because what they can do is, one, they can assess internally how kind of paralyzed or how weak that side that isn't working. And then they may be able to give you some exercises for that lower extremity or your abdomen that can help boost up the side that's not working as well. So I would highly recommend going to see a pelvic floor PT for that.
Okay. Thank you for that. Thoughts, please, regarding why drinking water heavily throughout the day results in elimination all day versus sipping all day until approximately 7 p.m. causes most elimination late and during the night.
Yeah, so you want to really sipping all day is actually the best thing. That's why, again, I like the water bottles that really kind of have the gradations on, because you don't want to drink all of your water in one big fell swoop either. But we do recommend that you stop your water intake about 2 hours before you go to bed. And what that does is it allows your body to process the rest of the water. However, the other thing I would say is that if you are getting up and going multiple times a night, whether you're sipping or you're gulping water, generally I would double check your swelling and how bad your feet are swelling. And then again, I would also maybe check your sleep. If you're supposed to be wearing a CPAP and you're not, that's going to cause you to get up and pee a lot. And I see that in a lot of my patients.
Okay, thank you. So I remembered that guy's question finally. It's about probiotics. So he says that he's been using probiotics for years, but he still has loose bowel movements and wanted to know, what could be done. Does it mean he's using the wrong probiotic, or, is it something more serious?
It might be not more serious, but it might be the wrong probiotic. So when that happens, I generally recommend that people try and talk to your doctor about getting a referral to a dietitian. It may be that you have a food sensitivity, and they can do some testing to see, because if you have a food sensitivity, so I'll throw out the most common one, which is milk. People are lactose intolerant. It might not be that you're completely intolerant, you're just sensitive to it. And if you cut down on the dairy in your diet, then that may cause your stool to be a little less loose. But a dietitian is really going to help you to be able to kind of hone in so that you don't have to do a complete elimination diet and eliminate all the fun stuff from your diet just to tell what you're sensitive to.
Sure. Okay. Another person's asking, do you recommend taking probiotics? And if so, which kind?
I do, and I don't really have one particular kind that I recommend. I often will just tell people to go to the grocery store and, take something over the counter. They all pretty much have about the same bacteria, because that's essentially, it's the good bacteria for your gut. So if you really struggle and you try a couple different kinds and they're not working, again, that's when I would go to a dietitian and double check and see which one you should be on.
Okay. And why a dietitian over a GI doc so many times that you're referring to a dietitian?
Yeah. One, it's easier to get into a dietitian sometimes, so it's easier to get in. And two, they might still recommend that you go to a GI doc, but a dietitian's really going to be able to help kind of suss out, is it food or is it some other imbalance that needs to be fixed?
Okay, thank you for that. Person wants to know, how do you improve chronic UTIs?
UTIs.
UTIs. Oh my gosh.
Chronic UTIs. The only thing that I can really recommend for chronic UTIs is drinking lots of water. The more water you drink to flush out the system, the better. And then talk to your urologist, because they may want to put you on a low dose antibiotic just permanently.
Okay. Another person writes, often dream of needing to pee, so I get up and I hightail it to the bathroom.
Yeah, that's very common. So that's actually, there's nothing we can do about that, but that's actually, I've had that and I don't have MS. So
I guess it's a good thing that you have the dream, right?
Exactly. Yeah. Usually that's how I know that I need to get up. That's like how my body finally wakes me up, is that in the dream, I'm searching for a bathroom and I keep trying to go and I can't. And it's because my bladder is actually full. So that's actually very common.
Thank you. Two last questions that I have. And well, until more people write in things on here, but right now on paper, will you discuss E-stim for bladder problems?
Yeah, so electrical stimulation is something that we will do if traditional strengthening exercise doesn't work, or if patients are really having a hard time finding their pelvic floor muscles, meaning that no matter how many cues I give them, they still can't do a Kegel or contract. And so what electrical stimulation does is that it helps you find those muscles. Now, a lot of people, and there are a lot of products out on the market that will advertise electrical stimulation that, oh, you can just do this and then you don't have to do Kegels. That is not true because what happens is as soon as you stop doing the E-stim, the muscles are going to weaken right back up again and you're going to need to do it again. So I highly recommend that you use it as an adjunct, meaning something you add on to help with your exercise, but not something that replaces the exercise.
Okay, thank you. There are, of course, more people typing in questions online, and I have one here on paper still. But I want to let everybody know again, this recording will be on our YouTube channel within 48 hours, okay? Everything is happening very quick these days. So if you want to be able to find that, you can either go to the MS Views and News website and then click on one of the banners for the YouTube channel, or just know that it is youtube.com/MS Views and News. Or you just go to YouTube and search MS Views and News, okay? And then you'll find it from there, all right? And also, we have a program that we're doing tomorrow night up in Daytona, Florida, and we have a nurse practitioner that will be driving across the state to come speak at that program, as well as we will have Jeff Siegel, who's a MS exercise specialist. He will be doing some talk on strengthening and stretching and other things as well. So I just want to let you all know about that. All right, 2 questions online. Are probiotics recommended to address the bladder and bowel issues?
Probiotics only for bowel. They won't do anything for bladder.
Okay, thank you. Last question. Is Miralax okay to take?
Yeah, so Miralax is absolutely safe to take. It's over the counter, and it can help with constipation. You generally, if you take it for the 2 weeks that it's recommended, and then you stop and you continue to have constipation, we will usually then recommend that you talk to a GI about taking it long term, but it's absolutely perfectly fine to take in the short term.
Okay, so again, thank you for that. But there's, of course, people had to type in questions real quick. And yeah, and one of them is from a guy, and he wants to know why you're only mentioning Viagra and why not Cialis or whatever else there might be out there.
Viagra is the most common, but Cialis also works. So it's just Viagra is the most common, and it's been the most studied in the MS population, but it doesn't mean that the other ones don't work.
Doesn't one of them work more quickly than another?
No, not necessarily. They both have different mechanisms of action, and it depends on if you have heart issues, whether or not you can use one versus the other. So talk with your doctor about that.
Right, exactly. Okay, last question. Really, everybody, last question, all right? Is cranberry juice a good daily drug to prevent UTI?
So it can help because what cranberry juice, the idea behind cranberry juice is that there's some acidity in it. And so that acidity helps to kind of keep the bacteria away. So yeah, you can drink cranberry juice. I recommend kind of the low sugar, pure cranberry juice, but it's not going to 100% take them away, but it can help. Absolutely.
Okay, awesome. Thank you again for everything that you did today. I mean, the answers were beautiful. The presentation was way beyond excellent. Okay, and so all my friends that are here online and everybody else who I don't know yet, and do hope to see you on future programs of ours, I do want to thank you. And there are plenty of people writing in right now how excellent this was, and they're thanking you as well. And we look forward to having you again online in a few weeks or a few months, I should say, and we'll take it away from there. Okay. So.
Okay.
Good night, everybody. Stay warm. Bye-bye.
Thank you so much. Thank you.